Asokan, cardiologist, Fatima Hospital, Calicut. I am happy to present my talk for CSI TV in connection with the annual conference at Hyderabad. How to triage a patient of ACS at emergency room. ACS is a common diagnosis of patients in emergency department. Underestimation results in increased mortality and morbidity. Misdiagnosis can have serious consequences. Patient may present with a typical chest pain or atypical presentation and more common in elderly, women and diabetes. Clinical presentation, 12-lead ECG is to be done in all suspected ACS within 10 minutes. Door to ECG time is 10 minutes. Atrial fibrillation may be common in NSTMI. Standard 12-lead ECG are limited sensitivity, then 30% cases may be normal. And as per the ACC AHA 2021 recommendation, patient with chest pain in which an initial ECG is non-diagnostic, series ECG to detect potential ischemic changes should be performed, especially when clinical suspicion of ACS is high, symptoms are persistent or the clinical condition deteriorates. Patient with chest pain in whom the initial ECG is consistent with an ACS should be treated according to STEMI or NSTMI ACS guidelines. The patient in which chest pain and intermediate to high clinical suspicion of ACS in whom the initial ECG is non-diagnostic, supplemental ECG leads V7 to V9 are reasonable to rule out post-valent infarction. Is a class 2A level of evidence B. And if you see the ECG presentation, 12-lead ECG to be done in all suspected ACS with the 10 minutes that we have already discussed, but the normal computation features from the standard 12-lead ECG other than ST segment and T wave changes. By maintaining higher negative predictive value, a machine learning model based on these novel features achieved 47% gain in sensitivity compared to commercial interpretation of software, that is 32%, and experienced clinicians interpretation. Then we will come into the biomarkers. The cardiac biomarkers are more sensitive and specific for myocytes, cardiomyocytes, and is organ specific and not a disease specific, may be elevated in CAD, non-CAD and non-cardiac conditions. Coming to the high sensitivity cardiac troponin, and it is helpful in diagnostic prognostication in patient with acute MI, and 98% value of high sensitivity troponin with reference to the population is actually assay specific. Total imprecision should be less than 10% coefficient value and able to detect cardiac troponin in at least 50% of healthy individuals. And if you see the estimation in healthy persons or micronecrosis and the steep rise seen with the acute infarction, the steep rise or high level of troponin will be estimated with the class 3 or class 4 generation of troponin, but early detection and especially healthy or early diagnosis will be useful only with the 5th generation of troponin. And if you come to the 5th generation, the limit of detection is around 3 nanogram per liter, and 98% cutoff value is 40 nanogram per liter, and coefficient value is around 30 nanogram per liter. So, it is about 10 to 104 actually is can detect the troponin level and compared with conventional troponin. And what are the caveats of a rapid algorithm? Algorithms only be used with all clinical information. A patient presents less than 10 hour chest pain onset and obtain additional cardiac troponin concentration 3 hours. Suspicion and patient with serial recurrent chest pain, serial cardiac troponin level to be estimated. And we come into the gender specific troponin, no difference, the cutoff values are same for both gender. And what are the clinical implications of high sensitivity troponin? This has got a higher negative predictive value for infarction and you can detect earlier acute infarction, and for to 20% relative increase in detection type 1 MI and twofold increase detection type 2 infarction. The level of cardiac troponin be interpreted as a quantitative marker of cardiomyocyte damage. The higher the level, the greater the likelihood of myocardial infarction, and elevations beyond 5-fold in upper reference limit have more than 90% postoperative value of acute infarction. Rising and falling cardiac troponin level differentiate acute from the chronic conditions. And coming to BNB is not useful for diagnosis of ACS. Transverse echo should be done in all patients during hospitalization of NST-MI, and coronary CT angiogram patients with low to intermediate pretest probability of ACS. And so imaging echo should be recommended in all patients at the time of admission, and it should be done in patients with cardiac arrest, hemodynamic instability early, and coronary CT angiogram and patient with high to intermediate low to intermediate probability of CAD when cardiac troponin or ECGs are normal or inconclusive. Gray score and measurement of BNB or pro-BNB should be considered to gain prognostic information. And coming to the clinical score or high risk tools to estimate the risk stratification based on this 5 component history, ECG, age, risk factors. Each of these troponin levels, each of these component may score 0 to 1. If the score is more than 7 is considered as high, and less than 3 is low, and in between is intermediate. So what are the recommendation of diagnosis of risk stratification as far as the ESC 2020 guidelines concerned? Diagnosis and initial short term risk stratification should be based on a combination of clinical history, symptoms, vital signs and other physical examination, ECG and high sensitivity troponin. High sensitivity troponin should be measured immediately or admission, and result should be obtained within 60 minutes, and 12-lead ECG should be done within 10 minutes, and ESC 01 or 02 guideline wherever it is available should be used as a class 1 recommendation. An alternative is the 03 hours estimation algorithm, if is available, is a class 2B. Use of copeptin is additional biomarker for early rollout of MI should be used when if cardiac troponin levels are not available. And based on the 2020 recommendation, the positive predictive value of MI based on high sensitivity troponin rule-in criteria is 75%, negative predictive value rollout criteria is 99%. So if patients rule-in should be admitted in CCU, requires early invasive coronary angiogram, rollout patients discharged early and managed as outpatient basis. And observe cases, this comes around 25% of the patients do not qualify for rollout or roll-in. Third measurement of cardiac troponin should be done at 3 hours, and echo should be done on follow-up. If troponin level is less than 5 nanogram at the presentation, can easily rule out the ICS. More than 79% rule-in and early angiogram is recommended. In between values, to repeat the troponin levels, if the rise in troponin level is less than 3, again it can roll out the ACS. If it is more than 5, rule in between 3 and 5, and you observe and consider further assessment based on serial estimation of troponin and other cardiac markers or imaging and angiogram if necessary. And POC troponin assay recommendation, majority POC assays commercially available at presentation cannot be considered high sensitivity assays. POC troponin assay have not been cleared and should not be used in isolation to rule out acute myocardial injury. Point of contact troponin assay have received a label may be used to rule in the potential myocardial injury and to inform decision making on follow-up examination with a high sensitivity testing. And if we come into the algorithm, the last how to triage the suspected ACS. A patient comes with 0 to 1 hour and is very low troponin, high sensitivity troponin, or low and no increase after 1 hour, and can easily roll out. But patient with acute chest pain, The other condition, if it is very high and high significant increase at 1 hour, rule in. In between you observe and repeat troponin at 3 hours echo. And ladies and gentlemen, I can conclude that accurate diagnosis of ACS has life saving implication, requires a careful assessment. High sensitive troponin assay measurements are recommended over less sensitive ones. It is recommended to use 0-1 hour algorithm, it is the best option, and 0-2 algorithm is a second best option. Used with the clinical assessment of pre-test likelihood of CAD, chest pain and history, and a 12-lead ECG. Use clinical scores, non-invasive imaging such as echo and coronary CT